Thank you all for joining us at the very first session of the Behavioral Health Echo brought to you by Bevel, Texas and the Center for Substance Use Training and Telementoring, CSTAT. My name is Shreya Prasanna and I will be the facilitator for today's session. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Bevel, Texas providers, please make sure that you identify yourselves during this session by entering your name and information into the chat, or if you're joining via phone, please email your phone number and name to beveltx@utisca.edu. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've shown up today, we're just happy you're here to learn alongside us. We're recording these sessions for later distribution through the Bevel, Texas YouTube channel. Any info you put in the chat will not be shared on those recordings. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. Or if you're on the phone, just press *6 to unmute. You can also use the emotions menu at the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. Or you can use the chat to share your perspective. There are a lot of us in this space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or our discussions. Towards the end of the session, the Bevel, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it allows you to access free continuing education credits. We are approved for CEs for social workers, licensed professional counselors, licensed marriage and family therapists, and licensed psychologists. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. For those who may be new to ECHO, ECHO stands for Extension for Community Health Outcomes. This is a model of lifelong learning and guided practice that connects community-based health workers with each other and a multidisciplinary team of subject matter experts to create a community of practice and learning. The model was developed by a liver disease specialist about 20 years ago to support primary care physicians in delivering life-saving on-site treatment for hepatitis C virus to uninsured or underserved patients. It rests on a simple realization that you can move knowledge instead of moving people. And if you do that enough, you can improve access, support the growth of the health workforce, and transform community health. A couple of things about the space. ECHOs thrive on conversations that acknowledge and include the perspectives of many. So we welcome your questions, your experiences, and your perspective in all our discussions. Remember, we're all learners and we're all teachers in this space, so your contribution matters. We'll follow a pretty standard structure for these sessions, starting with introductions of the Hub team and then a brief evidence-based didactic on a key topic related to behavioral health considerations in the SUD space. Following that, a member of this learning community will present a case using a structured form developed for this ECHO, highlighting questions they might have for this group. We will then discuss this case as a group. This is really the heart of all teach, all learn model of ECHO, and the space for you to share your own challenges, strategies, resources, and lessons learned with your peers and colleagues. We will then wrap up with a quick summary of key recommendations by a member of our Hub team. And with that, we will begin with some introductions. Dr. Antoine.
Hello, I'm very excited to be here today. My name is Dr. Dennis Antoine. I'm a psychiatrist by training, and I currently work at Johns Hopkins in different facilities, one of which is a methadone program that's hospital affiliated, but also work in a community-based program for substance use disorders with individuals who are unstably housed. So I've been in the Baltimore area now for 17 years. working in that space. So really excited to be here and looking forward to the discussion today.
Thank you so much for joining us. Dr. Aguilar.
Hello, everyone. My name is Clarissa Aguilar. I am a licensed psychologist by discipline, and I'm also the Director of Psychology and Training here at the Center for Healthcare Services. We are the local mental health authority for Bexar County, where we provide integrated health services, which include substance use treatment together with psychiatric services and integrated primary care services for our individuals that we serve here. I also serve as a behavioral health consultant in our integrated primary care clinics.
Thank you so much for joining us. Dee-dee.
Good morning. I'm Dee-dee Stout. I'm here in Northern California, actually in Emeryville, the home of Pixar Disney Studios. Yay. And I have been a professor here for about 30 years. I have worked in the substance use disorder, as we now call it, field for 35. I have a private practice here in Emeryville. Of course, most of it's online these days still. And I am also do a lot of consulting work with families and individuals, do a lot of trainings, keynotes in my area of expertise, and that's harm reduction, and particularly harm reduction psychotherapy. So I have authored a book. I'm working on the second edition now called Coming to Harm Reduction, Kicking and Screaming. And it's a little old right now, so hence the second edition, which should come out in hopefully January 2024.
Thank you so much for joining us. Katie.
Hi, so my name is Katie Dondeville. I'm a clinical psychologist. I work at UT Health San Antonio. I'm an associate professor there. And I lead a program called the Strong Start Training Initiative. The work that we focus on is training mental health clinicians in evidence-based treatments for PTSD, suicide, and other areas. And so I really come to this group thinking about the intersection of mental health and substance use. And so I'm really excited to be here today.
Thank you so much for joining us. Andrea Hepler.
Hello, my name is Andrea Havler, and I'm one of the program coordinators for the ECHO sessions, and welcome everybody.
Thank you so much. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm one of the program coordinators for the CSTAT. Thank you for joining and hope you enjoy today's session.
Thank you so much. Sandra Hines.
Hi, I'm Sandra Heinz. I'm with North Texas Addiction. I'll be doing the case presentation.
Thank you so much. And Adrian Lindsay.
Hi, everyone. Adrian Lindsay. I'm assistant professor in psychiatry at UT Health San Antonio. And I direct our Center for Substance Use Training and Telementoring at Bewell, Texas. And I just want to say a couple quick words about the program. One, thank you all for being here. We're really excited to see such a great turnout. I recognize some names and faces, so some of you may join some of our other ECHO programs. But I wanted to mention this program will be specifically for the behavioral health workforce, and that could be anyone from frontline behavioral health providers to leaders in behavioral health care. So we're anticipating a lot of social workers, counselors, psychologists, and on and on. And as Shreya mentioned, we do have CEs for all of your various disciplines. But our hope is to really help prepare the behavioral health workforce for these kind of ever-increasing substance use disorder rates that we're seeing, and of course the related overdoses. So we'll be covering everything along the substance use spectrum, from how to screen to what are the most effective behavioral therapies, and then all the wraparound services like medication-assisted treatment or peer services, and all of those other pieces that we know are really critical. And we would love it if you all would take the survey at the end of the session to tell us what you'd like to hear about here. That would be really helpful to us, and we can build our curricula out from there. And of course, present cases. So we appreciate Sandra going first this go around, but we'll be looking for someone for next month. So if you're open to bringing one of your cases and getting some feedback from this fabulous hub of experts, we would appreciate it. So thanks for being here.
Thank you so much, Adrienne. And thank you all again for joining today's session. With that, we will move on to our didactics. Maria, if you could please share the slides, and Dee-dee, you can take it away whenever you're ready.
Okay. Are we going to leave the slides in this view? I just don't want to get started before we get started. Thank you. So, thanks again, everybody, for being here. I have had a lot of fun just watching the different places coming up through the chat. So where people are working and where they are. Again, my name is Dee-dee Stout, and I am going to be speaking to the topic of stigma. One of the things that we talked about was how to start this program. And in the initial opening, we all felt that stigma was a good place to begin. And stigma is something that keeps people from seeking help in many different areas. But when we're talking about addiction and mental illness, it is really in particularly the thing that keeps people away. So it seemed like a good place to begin. Next slide, please. The disclosures you can read. We'll go to the next slide. And the learning objectives, I'll do my best to cover some of these. Obviously, some of these will be in the upcoming presentations that we do as well. But looking at the need for us to respond well to substance use disorders, or just people who are using drugs in some cases, looking at some of the common terms and sentiments. How do we feel about people who present with us in different areas? And that's a big one. Looking at how stigma and bias affect how we work with people, sometimes even the interventions that we use with people, and hopefully looking at how we can work with people in a team-based holistic care for substance use disorder. Next slide. Starting out with this quote from Scott Miller out of Chicago, who likes to say that psychology is the only field where the longer you're in treatment, the sicker you get. The more diagnoses that a patient winds up with. And I had never thought of it in that way until I studied with him in the early aughts and thought that's a really fascinating way of looking at this. On the one hand, we could say, well, more things are revealed. We get to know the person better. We see things more. On the other hand, it could be, why is it that someone is getting sicker, and why are we seeing them in that view? Perhaps it would be better to see most of their strengths rather than all of their diagnoses. I also want to say, and I'm just going to leave this slide here, that I think it's important also, before we do this exercise, which is going to come up next on stigma, that we need to operationally define stigma. All right. So forgive me for that, not having that in the slide, but it will come later, as I understand. So if we look, first of all, the definitions that I researched, and there were a couple that stood out for me. And one of them was that stigma is a mark of disgrace. And I think that really fits well. It is also a strong lack of respect for a person or a group of people because they've done something society doesn't approve of. That's exactly where we are with substance use. In a country that has declared that addiction is a disease, we still treat it as if it's a moral failing. And that is the stigma that then lends itself to creating stigma and unconscious bias. We also certainly see this in serving in other behavioral health realms. You could think of, again, people who use drugs, people who are medically obese, and more. That is still a stigmatized population too. So for providers, it's often our unconscious bias that leads to our stigmatizing our patients and clients. That leads to them stigmatizing themselves. There's an internal bias and stigma that occurs. And then, of course, families or loved ones around them are also involved in that. And so, you can see this ripple effect that goes out or comes in. Either way you want to look at that. Next slide, please. So I have a really simple exercise for you to do. I have some diagnostic labels and other labels of a person that I'm going to read off. I'm not going to read them all on the next slide. I'm going to choose a handful of them. And I'd like you to write down a word or two of the first reaction that you have. When you hear that word, what comes into your mind? I'm not going to ask you to share those unless you would like to, but they will be private. It would be nice if we could all break out into a nice Zoom room and chat about it, but that's for another training and workshop. So not today, but we will debrief a little bit at the end of this presentation. Next slide, please. So again, I'm just going to read some of these. Drug addict, child prodigy, cokehead, slut, genius, schizophrenic, classical pianist, college dropout, chronic pain patient, advertising producer, bipolar disorder, professor, and lastly, autistic. So in giving you a couple of moments to think about this, I'm curious if anyone would be willing to open their microphone or share it in the chat of some of the things that come up around those words. No?
I can share some.
Thank you. I am a
Person,
professor. I'm happy to call on people too.
no problem. So, drug addict, I think of somebody who's, kind of a criminal, child prodigy, someone who's really special and admired. Nymphomaniac. I really didn't have much.
That's an old one, huh?
And math whiz, obviously very positive. Someone to be admired. Divorced multiple times. Think about somebody has unstable relationships. Unstable, I guess. Cokehead. Again, somebody whose life is out of control, doesn't have a lot of willpower. Those are some of the things that I think, you sort of pop into your mind when you see these terms that you have to kind of counteract.
Yeah, thank you so much. Some of the other ones I saw in the chat were wild and faker, unstable, willpower. Anything else comes up from someone? Loser. Oh, good one. Coke addict, cokehead, drug addict, slut, schizophrenic, problematic. Yeah, problem child. Absolutely. Out of control. Classical pianist, talented, motivated. So we're getting kind of these two sides, almost like a Jekyll and Hyde going on, right? Non-compliant. Oh, my favorite words. If I never hear those again, I'll be happy, let alone I'm never writing them again. Med seeking. Oh, of course. Great. Junkie. I wondered if somebody was going to bring that one up. Inmate. These are great, you guys. Couple more moments here and we'll debrief. Psycho. Yep. Unstable. homeless. Yeah. Yeah. Pretty uncomfortable, right? This person we'd look at and go, oh my God, they're a mess. Sick, just to put it simply. Yeah. Thank you, everybody. So those are all diagnoses, labels, characteristics of me. They're all diagnoses I've received over the years. They are all labels that I've had to wear. Some of them I have willingly taken on, which is sometimes helpful and sometimes not helpful, right? And I think one of the things that I've done through my experiences, I've always tried to show up and say, yes, I have the education, and I also have the background, what we now call lived experience. And I think that combination can be really important for working with certain populations. It does not mean that you have to have lived experience to be effective, not at all. It means we need teams. We need everyone in the room. Like I say, there's a lot of room in the pool. So come on in. You know, we don't want to push people out as we used to. When I was trained back in the 80s, it was very much only people with lived experience that were allowed in the room to work with those with a substance use disorder, right? Those of you that had education only, we said, oh, you people don't know what you're talking about. And unfortunately, we missed a great lot of information that could have been helpful. And sometimes the people in the ivory towers of academia, which I've lived in for many years, you know, would also not listen to those of us with lived experience. They'd say, no, we know better. You know? So there was a lot of this back and forth, and there still is some of that stigma today. So there's another place that there's some stigma that really, I think, keeps us all from being as effective as we can be as providers. And ultimately, that's our job, is to provide services for people. Thank you. Next slide. So in looking at how do we reduce stigma, and you know, this looks like it's very easy. 4 or 5 things, no problem. And obviously, it's far more complicated. But we do want to start really looking at being trauma-informed and client-centered. So trauma-informed does not mean that we're going to treat the trauma. That is not necessarily your role. It may be, but it may not. But it does mean I need to understand trauma, and I need to understand the intersection of trauma and substance use disorders and other behavioral health challenges, because they do form this, you know, mess in the middle, if you will. Being client-centered means that the most important voice in my sessions with someone is the client. It's not mine. I may be an expert in many things, but I'm not an expert in your life. So I need you to partner with me. It also means I need to do things like ask for permission before I give information or perhaps give advice, and make sure that that person is ready and willing to hear it. And if they're not, to respect that and let it go for the moment. Doesn't mean I won't ever come back to it. We need to look beyond a patient or client's diagnosis and to see who are they underneath that. There are always strengths in people. Sometimes it can be difficult to see what the strengths are when people are presenting to us, because we tend to get people, particularly if you're working in a hospital or clinic, you're going to see people on perhaps the worst day of their life. Thank you, Mary. Yes, it is a true partnership. That is the only way that we can begin to reduce stigma. We must meet people where they are and where they dream. We must have an unwavering belief in people. If you do not believe that people can change no matter what, and if you don't believe that people have a right to behave in whatever fashion that they are in the moment due to circumstances, then I would invite you not to work in this field. Our job is not to make people make change. Our job instead is to give space to examine what's best for someone else with that client. So we like to talk about in harm reduction psychotherapy how it's about examining your relationship to a substance or a behavior, because that's what it becomes, is a relationship. Every client I've ever had that I've said that to is shocked that I use the term relationship. In fact, they'll say, I don't have a relationship with it. Yeah, you do. This is where we're going to start. And at the end of that examination, it's not for me to determine what's the right step for you. Maybe there's no step. Maybe you are perfectly content where you are. But I'll suspect that if you're in my office, you might want something to change. So let's start there and see what change you might be interested in. The last thing that's not up there, there are 3 real qualities that we need to have in order to both serve the people that we're serving, to do it ethically, and to care for them, as well as to manage this unconscious bias that can lead to the stigma. The first one is curiosity. I don't know if you can see him, but I have a little mini Cheshire cat back here. That's my reminder of my curiosity. We also need to be courageous. You know, sometimes we are going to have to buck up against the system, if you will. We're going to need to stand up for that client or patient in a way, hopefully, ethically and responsibly, but it may take courage to do that when everyone else is saying, no, 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 you should look at them this way. And lastly, it's about having a commitment, a true commitment to serve people, to help them to get what they want in life, not what I think they should have or should be. Next slide, please. I think it's also important in this discussion around addiction and substance use disorders and stigma, and we could add any other behavior in here, that really it has nothing to do with the drug use. That's where I believe that we have failed as a country. We continue to look at the drug use as the primary problem. Since it's a relationship with a behavior, we need to look at the relationship and ask the question, why is this person behaving in this way? What is it that they are gaining from this that we can't see, perhaps? We'll see the negative effects, but there's always a reason. Yes, Mary, thank you. Absolutely, always a reason. And sometimes people too, the people we work with, clients and patients, are not going to understand that reason. Right? But there will be reasons or reasons. And I've always said, why can't change be as exciting as substance use? If we really want people to come in to seek treatment for something, we got to put our best game forward. We've got to make it exciting. We've got to entice people to want to come in and at least have the conversation. So how can we do that? You know, one way is simply to invite people in, you know, give them a cup of tea, cup of coffee, glass of water, Coke, whatever it is that they want. Have them sit in a comfy chair, be relaxed. That's me. I need to be relaxed. And hopefully, you know, at least I'm modeling that for them, and say, so what brings you in? What's going on? And I appreciate that not everyone is working in that kind of a clinical setting. That certainly makes a difference. But whatever setting you're working in, it must be an invitation to come along on this journey and say, I will walk with you, regardless of where you're headed, even if it's risky and scary, but I will be here with you through this. Usually goes to trauma, low self-worth, low self-esteem. Yes, that is exactly how I felt. Why should I even try to make a change? Because when you're wearing all those labels, what's the point? So we really have to look at people differently so that they can start looking at themselves differently and give a reason to make a change, whatever that is. Next slide, please. And that's it. I would like to add just a quote from a colleague of mine. Helen Mentha, who is a psychologist in Australia. She says, we need to cultivate a mindset of deep curiosity and be on alert to the way we fill in the blanks with our own assumptions and worldviews. If we see a person as an equal partner, it becomes easier to also see them as a potential teacher. And when we honor a person's autonomy, our perception becomes less important because it's about them, not us. And I think that's where we started the session, in saying that we're all teachers and we're all learners. Thank you very much.
Thank you so much, Dee-dee, for a wonderful presentation. And I'm going to open up the floor for any questions or comments from our learning community here.
And forgive me, the allergens around here today are high, so the Kleenex is coming out.
Did anybody want to share about their experiences dealing with stigma with their patients?
Yes, my name is Mary Helen Lopez. And so I've always worked in corrections at the jails and probation. And, I've always, you get tested in regard to losing your objectivity sometimes, and working with persons that are dual diagnosed or because of the offenses they've committed, or just the stigma that our community, law enforcement, the jail has put on these, on these individuals. So, throughout years, I've learned that, to remember why I'm here. And like our presenter said, you have to sometimes step out of your safety zone and really advocate and remember why you're there. And, this is definitely inspiring and reminds me of that.
Thank you so much, Mary. I appreciate that. And thank you for the work you do. And that's a particularly tough place. My last teaching assignment was in our graduate department of, excuse me, counseling and forensic psychology. So I have not worked in jail, but I have worked with mandated people for most of my career. And it's tough. Yeah,
it is. And you have to remember the role that you're in. If you're hired by like the probation department, it's about community safety. That's your tenant. But, when I get cases, especially of persons who are incompetent, you feel really bad for them. It's because they're sick. But if they're I know you don't like this word, but if they're non-compliant, won't take the medication, then you have to make a decision. Are they dangerous to others? And what are we going to do?
Right. And sometimes there's nothing we can do, right? Because we can't hold people down and force them to take medication.
Right.
At least in most cases. Yeah.
Right.
Yeah. And so then it becomes a matter of, again, that conversation. Have I built enough rapport with this person that I can have a conversation that says, could I share a concern I have? Yeah. If you don't take this medication, here's what I'm afraid will happen. And then that could set you up for greater risk. While I appreciate you may be scared even to take the medication, and possibly for good reason. Yeah.
Thank you so much, Mary.
Yeah.
Thank you.
I just wanted to say something. Thank you.
Yeah. Hi, Diana.
Hi. Hi, everybody. I hope you are having a good Friday. Yeah, I love that you put the list and all of the things that people say. Yeah, and a lot of those were said about me, and it always equal to like whether I was a worthy person or not a worthy person, so yeah, so I always try to remember. So thank you for using the list and for the presentation. I always try to remember that I don't know what that person sitting across from me has been through. Like people didn't know what I've been through. And one of the things that really helped me, I'm in recovery too. I just got to celebrate 30 years on the 15th.
Congratulations.
But my worth was like this when I got into a program. It was like, you know, so yeah, to be able to help somebody build their self-worth and help encourage them and walk alongside of them. Thank you so much for
Thank you. Thank you for that. God, there were a couple of comments in the chat that I don't want to miss here. Okay, it's not helping me move here. Come on, you.
I can read that for you.
Can you do
Dee-dee.
that for me? It's not
Yeah,
letting me
absolutely.
move it.
Yeah. So we have a comment from Pastor Deb. Uplift Mary Ellen's words, working in restorative justice. We must always keep in mind the humanity of everyone involved. Nobody is just an offender or victim. And we have another comment from Mary Toll. As a person with lived experience, I want to thank you for revealing your labels. In peer support, we walk with people on their journeys. They're equal partners, and we have mutuality and learn from each other.
And she just added another bit here. Thank you for that, Shreya.
Yeah.
She says, I left a part out. I was getting depressed listening to the stigma. Yeah.
Well, thank you all. This has been a wonderful discussion. We will move on to the next part of our session. Thank you again, Dee-dee, for the great presentation.
Thank you.
And Maria, if you could please share the announcements. Thank you. The Center for Substance Use Training and Telementoring provides high-quality education and best practice for responding for substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.utisca.edu. Next slide. In addition to Behavioral Health Echo, we are launching another new program next month. The Recovery Science Echo is a research-focused echo program that will help grow a diverse workforce skilled in conducting recovery science research to address knowledge gaps in peer recovery support services. We will be meeting the third Wednesday of every month, starting from Wednesday, October 18th. So please to join us. We will be dropping the registration link in the chat. Next slide. Our next Behavioral Health Echo will be on Friday, October 27th. We will be talking about evidence-based screening. So please do join us. Thank you. And with that, we will move on to the case for today's session. Maria, if you could please share the case, and Sandra, you can take it away whenever you're ready.
Okay. So the case we have today is a client that we have with our services. She's currently utilizing multiple services with our facilities. She is 40 female, 42. She is gay. We're looking for assistance with getting her focused more on herself and the things that she needs to work on in her life while dealing with her ADD, ADHD. Her other mental health diagnoses are currently being handled with her medication. Some of her current challenges and what we've been dealing with. She is at our sober living home and was recently told us she was taking kratom to try to use a legal substance while working, and we had to explain that's not going to work for us, and she's no longer doing that. But you can tell that she's kind of struggling again, and she talks to us about her cravings. She's a very positive person. She's very helpful to others, but doesn't focus on herself. She kind of tries to help everybody around her and avoid her own things that have been going on. We've done sessions to just focus on her and her needs, and it makes her uncomfortable and emotional because she has to really look at herself and look at what's going on with her. She avoids anything that will cause her to tap into her emotions. She has a history of stimulant use, currently is a smoker, no opioid use, a little bit of cannabis use, and then the current kratom. I believe it's been 3 weeks since the last time she had used the kratom, though. She is currently received in our SOP program, our COPSD program, getting the recovery support peer coaching and living at the recovery house. She moved from inpatient to our recovery home in June of this year. And she said that it has been about 5 times now that she's been trying to stop with the methamphetamine use. And she's very committed this time to not becoming another statistic, is what she keeps saying. She's not currently taking any type of medication for an opioid use disorder, alcohol use disorder, or the stimulant disorders. Her current mental health is depression, bipolar, anxiety. She is currently taking Zyprexa, Depakote, Strattera, and Wellbutrin. She stated the Strattera is not really working at all on her ADD, and she's very happy with the Depakote. She said it's the first time she's really had a medication that's worked very well for her for the bipolar. She did have her thyroid removed quite a few years ago, so she does take the medication for that and deal with the low energy from that. We've been having her engaged in motivational interviewing, the cognitive behavioral therapy, harm reduction, peer support. So any type of other ideas that we can point her in. She states that she wants to go back to school. Also that when she does start working a lot is when she starts having really bad cravings or start wanting to use again. So she hasn't been doing that, but obviously that's not really a good model. You can't not work, so.
In regard to her, I was a person who was diagnosed with ADHD late. And one of the things I struggled with was just remembering all the things that would happen to me, losing money, forgetting appointments, family stuff. I mean, there's a lot that goes with that, and you don't feel really good about yourself, always trying to make up to others because you're afraid you're going to forget something, or I don't know, because, she seems to want to be a people pleaser as well. And I don't know if she exercises. That helps,
Yesterday, I believe, was the first time she said that she was going to start trying that.
Just walking, it really helped me. I've always, once I was diagnosed and realized that the walking really did help. And it doesn't cost you anything. You don't have to be at a gym, and, it's just a really good habit all the way around.
Okay. She's been making jokes about her recovery fluff that she's gotten since getting out of the inpatient treatment, and the Depakote also has been causing some weight gain.
And there's that ADHD website that is on the internet, and it really gives you a lot of information about why you do what you do. There didn't used to be a lot of research on women in ADHD, but there are such things now on, persons, that it's not just a kid thing. And I think maybe her educating herself on that would help her.
Okay.
Sandra, great presentation. I appreciate all of that. One piece I wanted to clarify, maybe two. I guess the two questions would be, how much does she smoke currently? And also, when was the last time there was a primary care doctor visit?
So the last primary care doctor visit actually was Monday. And she said they did her blood work. She has not received her results as of today. And I would say maybe a half a pack to a pack a day.
And I know we're kind of limited for time, so I do want to allow room for other questions, but I do have some, just some thoughts about the case so far, but maybe I'll pause to see if there are other questions from the group before I jump in.
Okay.
I was wondering how much she's working or going to school currently.
So that's back to the kratom thing. We found she was working doubles at a serving job. And that's when we found out that she had been taking the kratom. She didn't realize she wasn't allowed to take it. And that's kind of how she was getting through. So we helped her wean off the kratom. And she realized she couldn't be doing double shifts every day at the serving job, and cut back to just a dinner shift or a lunch shift. But right before this echo today, I just actually talked to her, and she stated that the business has gone down with her working the doubles. She's not even really making her weekly rent for the sober living, and wants to start looking into other options.
So is this like 20 hours versus 40 hours a week?
Probably, I would say maybe 20 to 25 hours, and she probably was doing 40 to 50. And it's the serving wage of $2.15 an hour with tips and not an actual full paid hourly.
Right.
One last
It's
question.
stressful.
Anyone that is financially depending on her?
No.
Well, again, in the interest of time, great presentation. I'll kind of start going towards the discussion and with some suggestions. My goal, though, is also to tie in the great presentation that Dee-dee made at the beginning, keeping in mind that our theme today is keeping at the forefront, compassionate care. How do we think about stigma and other portions of a person when we're looking towards treatment of individuals in these types of scenarios? What you brought up today, Sandra, is I would say an opportunity here to value all parts of this individual. ADHD is a primary focus there for certain. The kratom is such a new kid on the block, if you will. It's not a opioid that is approved for treatment of opioid use disorder, but it's something that is available in a lot of different places. So that's something we had to account for. What I would add to the picture, if I'm hearing it properly, is there are also some other things we should take into account. And a lot of people in my neck of the woods talk about strengths, needs, abilities, and preferences. And it sounds like a strength of hers in this case is that she's working. And for all that's going on, there's an opportunity there to really, what we would say, reinforce the fact that he's doing these things. And I don't want to take the thunder away from future presentations, but any opportunity to just say, hey, great job. And I'm sure everyone in the group is already doing that there. But sometimes that positive reinforcement can bring a person back to treatment over and over again, especially when they're having difficulties. So I would offer that to say, thanks for coming back. We know this is a hard situation. And like you said, to get, or as you asked, to get her focused on what's going on, just to say, well, you're here. What can we do today? And that's a therapeutic aspect of that. But again, I don't want to take too much thunder from some of our later presentations, which will look towards contingency management, which has been shown to be effective for stimulant use disorder for persons who've gone to methamphetamines. Now, one big piece that I'll bring into the picture that may not be the standard, depending on how she has been connected, is the biological aspect of things. As many probably know, after a removed thyroid, there can be large amounts of issues with anxiety and depression, fatigue, weight gain, and it sounds like this is what's going on.
He's got all of them.
Right. So that's that blood work that is coming back, that will be a very big part of the picture to figure out, should there be thyroid medications there to supplement what is missing, truly missing.
She does currently take that, and actually we had to go in for like an emergency refill and found out that the level that she was on before this last time was actually very high levels. So her thyroid levels were very, very low. So we're really kind of anxiously awaiting these results this week to see what's going on.
Excellent, excellent. I think that's a critical piece. The other piece that's a little bit more nefarious, if you will, a little bit hidden, is the molecule dopamine. I'll say it that way because that's how people will remember it. The medications that you mentioned to me are a combination of dopamine and norepinephrine that they're really hitting on. So Wellbutrin and Strattera will amp up the dopamine in a person's system. And she's also smoking a half a pack to a pack a day, which will also increase dopamine in a person's system. Those things, when they get that high, will increase anxiety, difficulty concentrating, and not to take away the ADHD diagnosis, but any opportunities to decrease smoking and reevaluate the need for all those medications would be great, because those things may be causing the storm. And on the other end of it, the Zyprexa also decreases dopamine. So it's a fight in the middle of the body to just go for dopamine in one direction or the other. So I think overall, this is an opportunity to really value all parts of what this person is going through, not only the social piece with the homeless piece, job, working very well, and trying to find maybe another option for housing, but then thinking biologically as well to make sure that part is really ideal and not using more medication than necessary. I think that's another type of stigma that's out there quietly that would just throw a medication at a symptom rather than looking at what the bigger picture is. So it sounds like you're doing a lot of great work to tackle the things that are identifiable, but smoking can play a big role. I would say that a lot, and then having a good conversation with the psychiatric provider, whoever that may be, to say
we're looking for a new one. We've been telling her repetitively that because she's in our sober living environment, in our sober living house, we need you focusing on you and your recovery. We can, in your health, like the job, all of that we need to be focusing on your recovery, your health. Let's get all that taken care of. And then from there, we can move on to whatever's going to come down the line.
And I mean, what you're saying is the common analogy I use in my sessions now. I just say we're going to do the alphabet, and we're going to start with A, B, and eventually we'll get to the deeper things that are harder, which it sounds like she has a difficulty approaching those and staying with those. So I think you're doing the right approach of saying, let's just chunk it to the easier pieces first. And as she gets that traction, there'll be more conversations about deeper aspects of the emotional piece. But it does sound like some of these things might drive and amplify the emotions, which would make it hard. So I think you're doing the right things, and the medical and the psychiatric could be spruced up to give her a better opportunity.
Yeah. And jumping in here too, thank you for this, because that's all of it. I mean,
we
always need to go first, go to the medical. I mean, that's the way I was trained in a hospital. So, then you rule out, those things. And now you start looking at some other things. And you always have the client with you, right? We're partnering right next to you, letting them know exactly what's going on and how do you feel about this? Now that we've got this information, what would you like to do with that? Those kinds of conversations. How does this change things for you or not, right? But looking at nutrition is another area that I would include here, because that is how we build the neurochemicals. And nutrition sadly gets left out, particularly of mental health and substance use disorders. And I realize, we can't be everything to everybody, but it can be as simple as focusing on just basic foods and making sure there isn't a lot of preservatives, just eating not canned peaches, go to the store and get a peach. Those kinds of differences can make a huge amount of difference. When somebody is coming off chemicals, particularly the high intensity like methamphetamine, often they're going to gravitate towards the sugary stuff as sort of a substitute, also with alcohol, obviously, which is mostly sugar. So that can be a really simple place to begin to make some small changes. I'm a big baby stepper, so small changes and see those results. I love that you brought up walking, Mary. Any kind of body movement is so important. We did a study at the hospital many years ago, and it was amazing the difference that exercise made of any kind. to, and this was with people using heroin and coming off in withdrawal from heroin.
Okay.
I just want to bring everyone's attention to a couple of questions here in the chat before the end of the session. So we have a question here from Timothy. Is she in trauma therapy or anything?
Not at this time.
Okay.
She's in therapy. She's in the COPS-D therapy that we have, but not trauma-specific therapy.
Is that her choice?
Yes.
Okay.
Well, her choice to not be in trauma therapy.
Right.
Has
it been offered and she said, I'm not ready for that?
We don't have that with our facility. However, I'm working with her to get her with an actual psychiatrist group, but she's never expressed an interest in trauma therapy.
Okay. So she's been asked about it and she's declined.
Yes, we did previously have one here and she wasn't interested in it.
Okay,
And
thanks.
thank you. And we have another question from Lorenis. Can she count on family support and friends?
No. I'm gonna go with a no. She has a very, very heavy family history of drug use, methamphetamine use. Her sister, I believe, was one of the people she used with the most. So she actually moved away from where her home base is and moved to where we are to kind of get away from that situation too.
Thank you. Thank you so much. And in the interest of time, we will move on to some recommendations. Dr. Antoine, if you could please just summarize the case and the recommendations, if possible.
Yeah, absolutely. So looking back at this great presentation, once again, thanks for bringing this case up. We're looking at an individual who really does have multiple domains in which they have some difficulties, but opportunities as well. I think the primary one that is with us here is the kratom. That's something we didn't talk as much about, but there'll be later conversations about that. And how do we, in the midst of kratom use, get her to engage in more types of therapies and things to bring her moving forward. So I would say, given the kratom, difficulties with trauma, anxiety, there really is an opportunity to partner with her. And that's the key thing that Dee-dee brought up, and making sure that valued partnership is there to engage in the fundamental pieces, the biological, the primary care, making sure all the things are in place to make sure the body's getting back on place, including nutrition. And I would put out there vitamins as well, if that's available. And then on top of that, getting to a point of comfort to tackle the other pieces with other types of therapies, potentially contingency management. But trauma would be at the forefront when she becomes interested. And that is the key for autonomy, our fundamental ethical principle, to make sure there is a choice there to make that next step for deeper things. But right now, it's a key of keeping it straightforward, keeping it effective with the biological. Then as you're doing a great job of attaching her with individuals and providers that can re-engineer the regimen a bit better to make it more effective. So a lot of stuff going on, but a lot of great work being done.
Absolutely. I'm going to jump in for a second too. How long has she been using methamphetamine, Sandra?
I don't have an answer to that. I know her and our birthdays are 10 days apart. So we're both 42. I want to say it's a good 10 years.
Okay.
About.
Yeah, it's a good chunk of time anyway.
Yes.
And so
yes.
we can, I think, pretty safely make the assumption that she's had trauma in her life. I mean, just telling me that her sister was someone that she used with, that is a traumatic situation to some extent, right?
Yes.
So I would double down on Dennis and saying that would be something I'd want to have a conversation with. And even if it's just asking her when she might be ready, what would that look like? What would need to happen for you to be ready to talk about this? And then the second piece, I'd say maybe helping her get a language for emotions first, because oftentimes we don't have the language. We don't know how we're feeling because we've been covering it up. That's the point, right? And so when it starts to present, all I know is I get overwhelmed. I get anxious or depressed, kind of the other way. And I really need help in figuring out what is this that I'm feeling and feel safe that I can have those feelings. This is not something to be shameful of or frightened of. And that can be another piece of it, which is also where some of the trauma work could come in, but one thing at a time. Thanks so much for that, Sandra.
Thank you.
Thank you all again for joining today's session. As a reminder, to earn CME credits, please complete a post-session survey using the link in the chat. If you'd like to present a case, please email the BWell Texas team. We look forward to seeing you at our next session on Friday, October 27th at 12 noon Central. Remember, you can also suggest some didactic topics or anything that you want to learn more about using our survey. So please do fill that out. Thank you so much and have a wonderful rest of your day. Bye-bye.
Bye-bye.